Welcome, everyone. We're very pleased to have Dr. Jane Simone with us. She is a clinical psychologist and currently a professor in the Department of Psychology and adjunct professor in the Department of Global Health, as well as Gender, Women, and Sexuality Studies at the University of Washington. For the past decade, her research program has focused on adherence to the strict therapeutic regimens used to treat HIV infection. Along with her colleagues, she has investigated how to conceptualize ART adherence and key methodological issues in the assessment and analysis of ART adherence data. Primarily, her team has sought practical and sustainable ways to promote lifelong adherence. Towards this end, they have designed peer support and counseling interventions and examined them with randomized controlled trials in New York, Seattle, and Miami, as well as in China and the US-Mexico border. The CDC has recognized both her peer and pager interventions as empirically based interventions having, quote, good evidence, end quote, of efficacy. She has published several reviews of HIV medication adherence trials, including a meta-analysis of randomized control trials. Additionally, she has published reviews of qualitative research on HAART adherence and medication adherence assessment methodologies. Dr. Simone.
Thank you for inviting me, and I'm honored to speak to this group. I know the department, I was just saying, your former chair has hired a lot of our alumni from our department in psychology. And I'm thrilled to be able to talk to you a little bit about a project we did on the US-Mexico border in El Paso. So please make yourself at home, get food. It's okay if you come in. I know some people will be coming in a little bit later. I don't have to talk to this group about what depression is or go through a DSM list of symptomatology, but I do like to start when I talk about depression in general, just to really remind ourselves of how devastating a condition it is and just how acutely painful it is for those who suffer from it. Those of you who haven't looked at William Styrone's thin volume about his autobiographical experience of his own bouts of depression, might consider doing so. It's really an enlightening book for a provider. The pain of severe depression, he says, is quite unimaginable to those who have suffered it. He called it, he said it should have a different disorder. It's like being crazy, he said, just in a different way than a psychotic illness. And it kills in many instances because its anguish can no longer be borne. The prevention of any suicides will continue to be hindered until there's a general awareness of this pain. We know there are huge comorbidities between mental illness and physical illness, and that's particularly true in the area of HIV, which I'll be talking about today. In fact, most studies show about 50% of persons living with HIV or AIDS will have some kind of diagnosable psychiatric disorder, including when you include substance use. And you can see here from a HCSA study that was done, here's the general National Health Pulse Survey domestically in the US, and here's a sample of individuals who are receiving care for HIV. So it's major depression, about a third of the sample, diagnosable with major depression, about 6-7 times as many as in the general household survey. Generalized anxiety disorder, about 7 times as high. Panic attack, 4 to 5 times as high. And no drug use is very rare, about half the sample engaging some kind of drug use. Another way to look at it is through a different sample which found similar results. So the light pink of the HIV positive, much greater rates of panic disorder, generalized anxiety disorder, dysthymia, depression, and any disorder at all. So we're looking at about a third to a half of the population, people living with HIV, has some kind of a mental illness. Now there's a complex relationship between depression and HIV, kind of the chicken and egg problem, which came first. There's probably there are a lot of third factors that would put people at risk both for acquiring the virus and for acquiring or developing depression at some point in their life. But we do know that having depression increases your risk factors, the behavioral risk factors for HIV. So these would include inconsistent condom use, having multiple sex partners, choosing high-risk partners, being involved in sex work, having sex under the influence of drugs or alcohol, and sharing needles, unclean needles. We know on the flip side that having HIV is a risk factor for developing mental illnesses like depression. So both getting the shock, the trauma, a stressor of the diagnosis itself, and the side effects of medication can increase one's vulnerability to depression. There's also some interesting research on whether or not the diagnosis of a HIV diagnosis, especially with people who don't have the resources in a very highly stigmatized setting, might actually lead to PTSD, might be a stressor severe enough to actually lead to a PTSD diagnosis. Either way you get HIV and depression, once you have HIV, depression definitely worsens HIV outcomes. That's why it's important to look at it. So direct effect of depression on HIV outcomes, viral load, CD4 count, progression to AIDS, and lowered immune functioning. Depression in general, we know, is linked to symptoms of HIV infection, higher viral load, again, disease progression, shorter survival time. And I think the most powerful graphic, I'm going to take a sec just to show you Jeanette Ikovics' study, which she did with almost 1,000 HIV-positive women. And this is a survival curve. So over time, how many people, the outcome is mortality, death. So HIV mortality related to people who have, here's the chronic mental illness, here's if it's just, depression, here's intermittent, and here's limited or no depression. So over time, the survival drops precipitously for people who have depression. So this affects actual mortality. And when you look at it, what's even more incredible, I think, is adjusting for these factors. You have a little bit, not as steep as a decline in survival, but look what you control for. You're controlling for baseline CD4, viral load, presence of other HIV-related symptoms, antiretroviral medication use, as well as age and unemployment. Even all of those things being held equal, you still have this precipitous drop towards death when people have depression. So it makes us think there's definitely room for intervening in people experiencing depression with HIV. And how does that come about? How does having depression actually lead you to die more quickly in HIV? And we think one of the main factors, one of the main mechanisms of this is non-adherence to HIV medication. Depression predicts non-adherence across various medical conditions. We know this, including HIV. And Steve Safran, he'll be talking a bit about, because we looked at a lot of his work. He's at Mass General. I looked at a lot of his work for this study and others, has found that depressive symptomatology is negatively associated with adherence, even above and beyond these other factors: social support, your self-efficacy about being able to adhere, your beliefs about HIV as a source of punishment. If you all these over and above, if you have depression, it's related to poor medication adherence in HIV. I guess I could say a little bit of a background. I meant to ask for this audience. This audience is mainly, I know some of you work with HIV or populations impacted by HIV, but is there anyone specifically working in HIV here? Okay, so there's also broad, and most of you doing clinical work currently, in psychiatry or clinical work currently. How many people are engaged in research as well, primary research? Okay, so a few. So we'll keep it. So I'm looking forward, and I meant to say I will save time at the end for discussion. I definitely want to hear from people actually working in the field, which I don't as much anymore. I'm a licensed psychologist. I do some supervision, but I'm not working actively in the field anymore. So I actually like to give these talks to people who are working in the field and get their feedback about how much of it they think is actually relevant for what they're doing. And again, I'll be talking a lot about HIV, but like I said, working in Harborview, you'll be working with a population has a lot of chronic medical conditions. I think a lot of the socio-demographic characteristics of folks that are affected by HIV as well. So I think a lot of it will be relevant for other disorders. Okay, so I will talk specifically about the project we did on the U.S.-Mexico border. So we worked on the other side of El Paso, Texas, Juarez, Mexico, and the state of Juarez, and in a city of Juarez in Mexico. Some of you know it. It was a city where there were disappearing women for years. It was one of the most violent cities in the world, even worse than Baghdad, even during the war. So horrible, horrible drug problems on that side of the border. It's interestingly, on the other side of it, El Paso actually has been voted one of the safest cities in the country. And it has to do with differential enforcement for punishment for drug-related crimes and violent crimes. And Mexican perpetrators do not want to be caught for doing anything. There are a lot of crimes of kidnapping across the border and then murder once you get to the other side. But it's actually a very safe city to work in. But the other side is not. Along the border in general between the United States and Mexico is an area of really low resources in terms of health care, mental health care, and high in terms of actually the HIV epidemic, like a lot of border areas. There's actually high rates of HIV along the border. About 33% of Latinos that we interviewed for some preliminary work for this project were found to have a diagnosable mood disorder, mainly depression. And we know that the border is dramatically underserved, with very few, especially providers who are fluent in Spanish and familiar with an HIV treatment context. I can tell you specifically, when I was working there were 4 licensed psychologists. One had lost his license in another state, so was working in Texas, was willing to take him without a license because they had nobody else. A couple had been trained in other countries as well, and there's only a 4th who didn't speak Spanish. We know about the shortage of mental health professionals worldwide, but I want to actually look at the numbers and see how bad it really is. So if we look at Seattle, the population of individuals per one full-time equivalent psychiatrist, about 7,000 people can be served by one psychiatrist in Seattle. And these are the lists of the time available for each patient, whether you have a low mental health need or a high mental health need. So you have ability to serve, even with a low mental health need, about an hour per person who needed it. And you can see how the numbers just plummet. Even in rural, underserved areas in the United States, it's very different. There are states in the Union with only a couple of child psychiatrists. So England isn't doing so well. China, not bad. But when you get to the developing world and the Southern Hemisphere, Africa, Kenya particularly, with a lot of UW research and some of my own research is taking place, very little mental health capacity. In Nigeria, up to 1.8 million people being served by a single psychiatrist. And you have to realize in these places, when you do find that psychiatrist, that person is not sitting out providing care, 12 seconds to each person that comes. They're usually running the public health departments. So this is even an overestimate of what's available. And you've heard that statistic that there are more psychiatrists in the city of San Francisco than the continent of Africa. This is true for a clinical psychologist as well. Here's a chart that shows the number of psychologists per 100,000 individuals in a population, so 1 to 100,000. And most of Africa, East Asia, gets a little higher. So in the United States, 10 to 50 per 100,000. So a huge order of magnitude in terms of the difference. So what to do about this issue? One thing that a lot of people in the global mental health community are talking about is task shifting or task sharing. So that the idea, if you don't have highly educated, highly trained, PhD level, or those with an MD to provide services, that maybe we can share these tasks with someone who's not as highly trained. Maybe nurses, maybe psychologists or psychiatrists, maybe lay health workers, maybe peer health workers that don't have much formal training at all even. So we know, and when we talk about shifting, it means completely giving the task over to someone else. But sharing might mean that some of the burden, maybe the higher level supervision, is done by the more trained professionals, but then they train the trainers and other people are trained to actually do some of the frontline work. So there's a lot of interest in how these models might impact care, especially in low resource settings. So we know there are well-defined, manualized psychosocial treatments that can be effectively applied by paraprofessional individuals, so that in this kind of task shifting approach. But there are virtually no well-defined, linguistically and culturally appropriate manualized treatments for depression and non-adherence among Latinos. And I could have said this even more broadly. In the United States, there are very few really Spanish-speaking or Spanish language versions of manualized programs and evidence-based treatments. So we're going to use, what we focused on is Steve Safran's cognitive behavioral therapy for adherence and depression. So Steve's a clinical psychologist working at Mass General and Harvard in Boston, and he mainly works in HIV. He has developed a manual using CBT, pretty basic CBT strategies for adherence and depression with chronic illness. It's an evidence-based intervention, it's been tested a couple of times now, that looks at the association between depressive symptomatology and poor medication adherence. Remember, I'm talking specifically about HIV, but a lot of this applies to other chronic illnesses, so I'll try as much as I can to speak broadly about it. But we know that medication adherence is a huge problem, $1 billion in healthcare costs, especially with a chronic illness, that over time people have difficulties adhering to their medication. And what Steve found is people are depressed, of course, have even a harder time. But if you treated just the depression, or if you had interventions where you treated just the adherence, you didn't do as well as when you looked at both simultaneously. So he has a manualized approach that looks at both simultaneously. And the idea is that decreasing depression will directly affect biomedical outcomes. In HIV, these are your viral load, the amount of virus you have in your blood, and your immune system, your CD4 count. And that indirectly affects these outcomes through problem-solving skills, motivation, enhancement, and memory. And I'll tell you a little bit. Again, this is not a group I have to explain what CBT is, but I will tell those of you who are working with the chronic medically ill population might want to consider taking a look at its manual. And only there's one written for the provider, but there's one written for, he has a patient workbook as well. That again is very helpful across conditions. But it starts with an orientation to CBT and the model of depression, especially talking about with specific reference to the particular illness, whether it's diabetes, heart disease, HIV, and how it impacts the two. There's an enhancement component using motivational interviewing to encourage people what they're thinking about in terms of their depression treatment, in terms of their adherence, where they would like to be. And then there's a component of life steps, and these are steps towards more complete adherence. This actually was this step here, this third step, was evaluated separately as a very effective intervention for HIV adherence. But as Steve found out, you need, for people who are chronically depressed, it often wasn't enough. And you had to treat the depression as well as the adherence together. And it's a series of about 11 steps that focuses on some of them very straightforward, using electronic reminders, getting access to your actual information about your medication, filling up your pill box together, being able to take steps to anticipate and how to deal with relapse, using cue dosing to control when you want to take the medication. He also, in the CBT for AD, then the rest of the steps look more like more traditional aspects of cognitive behavioral therapy. So there's behavioral activation in terms of activity scheduling. There's the cognitive component, looks at adaptive thinking and cognitive restructuring. There's a problem solving, so teaching people problem solving techniques so that they can deal with barriers to adherence, barriers to obtaining care and engaging in care. And then there's a relaxation training, using mainly diaphragmatic breathing at the end. There's relapse, there's prevention as well as maintenance and review at the end of it. So this basic package that it gives one-to-one individualized therapy. It's been tested using PhD level, Harvard-trained psychologists, and it's found to be very effective. What we wanted to do was to take this model that Steve developed really in the Northeast and apply it in a very different population, this population living in El Paso. And there are different ways to adapt or modify interventions. I'm sure a lot of you do it in your work every day. I mean, in a way, we have to adapt what we do for every individual patient sitting in front of us. But there are vast differences, I think, in terms of the population that this was originally defined for and this population that we were hoping to impact in El Paso. There are actually adaptation processes, because it's done so frequently now. There are a couple different ones. This is one that we used from the Center for Disease Control. It's called a map of adaptation. It's basically a systematic approach. How do you take an intervention that's worked for one population and see if it'll work in another? And the main problem is, they say with adaptations, what you have to do is you have to maintain or retain the key elements of an intervention. And then you can sometimes adapt the content of the process of how it's done. The problem is how many interventions come with underlining for all the key important elements. They usually don't. And they weren't tested in a way, they weren't dismantled to tell you, you know what, with this guy, 9/10 of it you can throw away, you really only need to do this one session. So it's difficult when you go to adapt something and say, well, what can I leave out because it's too complicated, because it's going to be hard for someone else to do, because I can't translate it well, because it's culturally inappropriate. It's difficult to do that. So hence these more systematic adaptation processes. So the model incorporates input from community members. This project that we did was had a lot of input from the community, and I think that's very important. It looked at the experiences of experts, both in research and the target population, and continuous feedback through the adaptation process. There's an article that specifically outlines the steps of the CDC adaptation process, but I can tell you, applied to our study, this is what we did in 4 steps. So we looked at the factors associated with our population, again, Latinos living with HIV on the border. We looked at current evidence-based interventions, other EBIs used in this population. There weren't really any that were linguistically and culturally adapted. We reviewed stakeholders, like the persons that worked at the clinic, community leaders, the CEO at the agency that we worked with. And our next step was that we selected CBT-AD as a likely appropriate intervention and developed a plan to linguistically and culturally adapt it. So we had to translate everything. Everything was all in English, and look at which parts were culturally appropriate. We finally modified it with information from the same people, did pre and post tests, translate it, and then test the feasibility with an intervention in the community. We worked closely, as I said, doing some kind of community-based participatory work. Research is usually the most helpful, especially when you're dealing with adaptations. So we worked with a scientific and an administrative community advisory board. So we got people, both in our research colleagues and people working on the ground in the community, to work with us. It was interesting, actually, when we went to El Paso. I remember the first day we sat down with some of the leaders at the clinic, and they said that a lot of research had taken place at the hospital, but no one ever had come to talk to them first. And I thought that was startling. So it's good to know that that should happen. You know, when you're working in a clinic, it's perfectly appropriate. If people want to do research, they should come and talk to you and get your feedback, and as early in the process as possible. We had a patient cab, so 6 patients. I think it's important to interview them separately from the providers so they're more free to share with you. We had meetings where we kept up in contact with them, and we had events where we had simultaneous interpretation. It was difficult always doing things bilingually, but I think it was important to provide a welcome to a broad audience. We started with some qualitative work even after we did this preliminary work. We had focus groups that were conducted in Spanish. So we had females living with HIV and gay identified males, a very different population on the border, and we thought we should look at them differently. We also looked at treatment experienced adults, those who have been on HIV regimens for a while, to get their opinions about how best to approach adherence. And we did some qualitative analysis with Atlas software, and we conducted everything in Spanish and then translated them later into English. We were most interested in the qualitative findings of what was going to be different with this population. And we weren't surprised to find issues related to HIV disclosure. Who can I tell about my HIV infection? It's a secret. We met men who were in their 50s, gay, identified as gay, never disclosed, never come out of the closet to their own family, their parents, and they were good Mexican sons still living with their parents in their 50s, making it very difficult to date, you can imagine. Haven't told the parents about being gay, certainly didn't tell them about their HIV infection. So they had to take their medications. They were hidden around the house, and they had to take them without their parents knowing about it. Some of them were making strides towards trying to separate a little bit from the parents, to have a little bit more of an independent life. I remember, but this is all relative, right? So I remember one man in the focus group saying, you know, it just got to be too much, hiding my HIV, can't take my pills, I make excuse to go to the doctors, I can't date, I can't bring someone over here. So I decided just to move away from my parents. And he later in the group, it came up that he had moved 5 miles across town from his parents. He still saw them every weekend. He was in close contact with them every day, but him, this was a huge leap away from his parents of independence. So issues of disclosure were really key in this population. Also stigma related to religion and spirituality in particular. So very devout Catholic population for the most part, concerned that homosexuality was a mortal sin, not seen positively by the Catholic Church, not feeling like they can't be open about it, trying to struggle with their own faith, how that fit in, and because they still had a strong faith, but trying to understand how being gay fit in with that, and a stigma because of that, and stigma on top of that with HIV, which was associated, for the most part, the main risk factors on the border are men having sex with men, so it was kind of confounded as having HIV and potentially being gay for the men coming out. Certainly when they were 50 years old, had never been married, living at home and saying they're HIV, there was going to be the presumption that they were also gay. Family support was a huge issue, as I said, with this young man being, you know, even daring to move 5 miles away from his home, that being a big deal. Depression adherence were key, as we predicted in this population. We asked them actually about doing group work for depression. Would they be interested in that? They said they weren't interested in that for a couple of reasons. It was already offered in the community. It was also thought it was a low budget way to do it, provide groups. You can treat more people and more efficiently. But they said there were problems with confidentiality. So they didn't want to be in a group. They felt it was important. What they needed was individual therapy here. Financial stress also was a big issue for this group. Related to even buying medications or paying co-pays, paying for medical services, and even access. Most were living on less than $10,000 a year. What was interesting, the women expressed more difficulty in living with HIV. For one thing, they didn't have as much of a community. If about 2/3 or more of the epidemic was among men who had sex with men, there were more groups for them. They had a community of men that they were involved with. But a lot of the women were infected through their husbands. They had no idea their husbands were engaging in sex with other men or injection drug use, and it was a shock for them. They had done what they were supposed to. They'd been told by the church. They had married one man. Most of them had 1 or 2 sexual partners their whole life. And then after they had children, they found out not only does their husband have HIV, but they do too. And then they felt very prohibited from disclosing to anybody else, even in their own family, because again, of the stigma that then they'll find out the husband's gay. Issues related to physical appearance. This is particularly when the drugs were a little more toxic and a lot of side effects were really visible. Psychosocial intervention efforts could benefit, we thought, from these culturally specific issues and really attention to all of them as they came up with stigma, family relationships, or impact of adherence and disclosure. But as you know, about basic outline of CBT really doesn't cover these things. It's really not mentioned at all. And we spent 90% of the focus group talking about these issues. So to adapt it, what we did was look at it both in terms of the content and what we were going to provide and the process of how we were going to provide that. So in terms of the content, we informally assessed how relevant these domains would be in the most salient concerns. And what we wanted to do is explore how these overlap with depression and adherence so we could begin working from the same narrative. And we'll tell you exactly how we did that. But we basically thought these things were very important. And before the therapist could make a connection with the person, they had to understand their story, had to understand their disclosure issues, how the stigma was, what it was like for them to come out, their issues around homosexuality and their faith. And in the process of doing this, we try to incorporate traditional Latino values and apply them in our interactions throughout the intervention with the client. And I think that's probably the best example of this is when Steve Saffron, who's a friend of mine and describes himself as an erotic Jewish man, came to give a talk in El Paso, and he demonstrated for the community. We opened this up to the community. Anyone could come to learn about it. We had 50 to 100, I guess closer to 100 providers from across Mexico and the U.S. come to learn how to do CBT because there's just a dearth of any information about empirically based treatments. So at one point, Steve did a role play where he, as the provider, was talking to the patient. And a typical, those of you who've seen some of the early interviews with Beck and the other early developers of the CBT, Ellis used to give a talk every Monday night in New York City. I'm sure he's not doing it anymore, but when I lived there, I saw him do it once. And you can imagine it's very combative, it's very verbal, a lot of high energy, a lot of almost to the point of almost argumentative. And this is not a presentation style that the audience was really accustomed to. So they're almost, to say that they were aghast would probably not be too extreme. To say in hearing that this is how you were supposed to treat your client. So the first thing that they would do in meeting a client would be say hello. Again, these values, respect for them as a person, individual. How are you? How are you doing? Where are you coming from? Confidentiality, sympathy, the idea that these smooth and interpersonal relationships and having a personal relationship was very important. Asking about family, how are you? How is your family? What are they doing? You know, how long have you lived here in the United States? That was a very important part of it. And this might go on for a good part of the beginning of the first session. Certainly before you could get in and say, we have a 45-minute interview today. We're going to start right in because we're limited in time and we're going to jump right in and get to the task. So it's a whole different approach to developing the relationship. So what we decided to do is have a whole additional first session. We really said just could not jump right in and say, task number one and your homework is going to be this, but we spent the entire first session in saying we have got to have the therapist get a chance to get this, know this person, has to tell their story. You know, many of them hadn't told anybody. When I first did a study in Los Angeles, 30% of the Latino men we worked with hadn't told anybody after 1 year that they had HIV, not a single person. So to have a chance to just share their issues about who they talked to, who they haven't, what it was like to get the diagnosis, how they got it, were they surprised, had they told their family, maybe their younger sister knows they're gay and she's been supportive. They have a group of friends, but they don't have a steady partner, or they do, or they're still involved with their church, but they're completely closeted there. All these issues were really important for them to make a connection with a therapist, to want to come back, and because these were issues that were going to come up during the course of doing the intervention. We further adapted it in some ways. We saw that really the increased relevance of the behavioral activation was really key. In needing low or no cost options that were really relevant. Some of the examples given, you know, when you look at a CBT manual or you look at a behavioral activation manual, go to a spa, go to a bowling alley. Have you been to El Paso? You'll see what a state looks like when you really take away government spending. Nothing. It's really a park. So really limited in terms of the things that they could do. So we had to say things like playing loteria, incorporating family interactions, things that were available, and more other focused activities. A lot of the CBT, there's an underlying individualistic assumption in it that you can do things for yourself. You deserve it. You have a right to do this. This is what you get. You worked hard, so now you can treat yourself. That didn't really resonate with our population. Yeah.
What is loteria?
Playing like a lottery game, like buying tickets, engage in a lottery. I did that, and playing in a social way with other people, doing gambling games that they did with each other. And just things that involved more, with more of a community or family aspect to it. cooking for family members, volunteering, donating these items to charity, doing anything that just didn't have a high cost and that they could focus on. We adapted stories and metaphors. Parenting, the baseball didn't resonate with them. I'm probably looking back, I should have used something in soccer or football. But we used parenting instead as kind of a metaphor for some of the things. We found that adaptive thinking, incorporating information gathered during cultural exploration session was key. So to think about some of their issues around, I have HIV, is this my punishment from God? Is this, is my family right about this? Can I not tell anyone because it's my fault? And so bringing up all the things that came up in those first couple sessions. And then he chose our sayings that we had to change and simplifying the terminology. Cognitive restructuring was particularly difficult for them to understand and to adapt. Very difficult thinking out what were the different ways, the distortions, trying to remember what those were. It was very difficult for them to think in those terms. And then I'll tell you one example. We have a range of literacy, but basically low educational literacy. There was one man that was a former boxer, and he obviously had some head trauma. Very low literacy, very low cognitive ability, couldn't do much of the homework, couldn't do much of the reading. But we were able to change even further a lot of these materials to make them almost all visual. And for him, the best he could do was with cognitive restructuring was thinking about coaching. So that's what we did in boxing. He thought there were different kinds of coaches, the supportive ones that were really understanding and positive, and the ones that were really punitive and would yell at the boxer. So for him, he saw in his head two different kinds of coaches. We talked about him in terms of restructuring his own self-talk around the kind of coaches that would be most helpful for him. So let me tell you about how we tested it finally, the research part of it. So we worked with a community agency, La Fe, in El Paso. All the participants were adults. They had to be on their medication for at least 30 days. They were of Mexican ancestry, fluent in English or Spanish. We had bilingual therapists, so we could do both. Had to have some depressive symptoms. We chose Beck at 10 or above. And any reported non-adherence. I should say something about the symptoms. Steve, in the discussion, maybe you guys can talk about this too. We often find that some groups underreport depression, and we're seeing this now with the study we're doing at the Tulalip tribes with American Indians, that there's a stigma around depression that people didn't, although they could identify with a lot of the symptoms, they would not overall endorse being depressed. So we thought, although I think there's higher levels of depression than we actually got, we ended up dropping our eligibility criteria so people go into the study a little bit earlier. If they had dementia, psychosis, or really high drug use, they were excluded from the study. In the control condition, we had treatment as usual at the clinic, which was referrals to therapy when they needed it, and medication. The providers, the HIV docs, would provide medication when they needed it in extreme circumstances. But otherwise, everybody got an electronic pill box. This is a way both to assess how they were taking their medication. So it's a box that has different compartments for the pills, and every time you open one, it records it, and then we later can connect it. This one was actually connected by phone to the clinic, so we could see and monitor their medication adherence whenever they opened it. They knew this. They knew we were monitoring them. And then it actually had an alarm function. So people who were in the intervention with two arms, the control, the intervention condition, actually got an alarm reminder to take their medication. We had monthly check-ins for people in both groups, either through having their therapy or to check on the pill box. And we also wrote a letter to primary care physicians letting them know they were in the study, that they had qualified because of their depression. Of course, we got permission from the clients to be able to do that. So it's always a difficult dilemma. You're targeting a population at risk for something, but then you're not providing a service for them. So we felt like with this way, we're at least letting the clinic know and told them to treat them as they see fit without any regard for the study, because they may or may not be in the intervention condition. So in the condition, it was a 6-month treatment, 14 to 20 sessions. We found we took longer to talk to the patients on the border than Steve did in the Northeast, a mainly white gay male population. In the preferred language, so both Spanish and English. We had 2 follow-up booster sessions at the end of that during the 6-month period. Again, we used the electronic pill box. We had the reminder function for those in this arm. And again, they all got the letter to the primary care physician as well. We paid them for being in the study. They got about $20 for each of the assessments. And we did pay them to come to the intervention session. There's a lot of big ethical and methodological issues about doing that or not. But a lot of them came across the border, waited in line to go across, paid to do that with transportation costs, and took the time to come back. And we didn't think $15 or $20 for doing that was coercive. We didn't think there was anyone who came just for the money in doing that. So they had the chance to earn some money being in the study. Overall, just a quick visual of what we did. So we had the two arms. You had standard of care, or you had the intervention condition. You had the pill box that was either silent or alarms. You had training on that. You had monthly check-ons. This is a way of kind of balancing and attention control for the people who were in the study. You know how just coming in and seeing someone can be helpful no matter what you do. So we wanted to make sure they came in at least once a month. We followed them for 6 months, had some booster sessions, and then 9 months when they returned their pill bottle. So of the 295 referrals that came in, only 42 were ineligible, 33 couldn't be scheduled, an additional 5 declined to participate. So we got 252 people who completed a screening survey, but most were excluded because they weren't Mexican or failed to meet the inclusion criteria for depression. So interestingly, only one individual declined once he had gone through the full screening to be in the depression intervention study. They knew they'd be assigned to one or the other. So for outcomes, we looked at both self-report. We used a Beck depression inventory, 21 items. We also used a MADRS. I don't know how many of you are familiar with this research instrument for looking at levels of depression. They find that over time, it's a little bit more objective measure than a self-report measure to actually interview someone. And we had one of Steve Safran's colleagues at Harvard do supervision on Skype or over the phone for about 20% of the patients, making sure there wasn't a drift in terms of the recording. We used a visual analog scale just to check mark 1 to 100. How's your adherence? Let us know, 0, 5, 25% on a scale. We used the pill box over the last 2 weeks to get an estimate of valid openings close to the time they were taking their medications. We deleted the duplicate openings. So we had self-report and more objective outcomes for both depression and the adherence. We also had some biomarkers in HIV, again, a viral load, the amount of HIV in your blood, the CD4, measure of your immune functioning, we got from patient medical records. And at baseline, we got samples drawn from close to when they were enrolled. Again, we did the 6 and 9 month follow-up and log transformed the viral load. So participants by arm, the baseline data were available for all 40. So we had 20 and 20. This is a small study, an R34 developmental study from NIH. The idea was to pilot this, get all the materials together, and then get funding for a later larger study to test it for efficacy. 80% of the participants had complete data, 3 missed, single, 14 additional dose. Intervention participants completed an average of 10 sessions. There were no significant differences in retention by arm. We're happy to see that. You know, often people drop out of the control arm if they're not engaged or if they're being worked too hard in your intervention study. Demographics, there weren't many differences, big differences between the two groups, whether you're in the control group or the intervention group. About half and half spoke Spanish. There were about 3/4 men, gay and bisexual men mostly. Most were, this is one slight difference, there were more people were partnered in the intervention group, but mainly about half are unemployed, not working, usually on disability because of the HIV. About mid-30s over the years, we're seeing our HIV studies, people getting older and older, living longer with the virus, which is good to see. Very indigent population, and have been 10 years about since their HIV infection. So our strategy, again, I mentioned most of you weren't researchers, so I just quickly, we used a GEE approach over time to look at the difference between arms, those getting in the intervention or not. This approach allows us to look at all the data, even when we had some missing information. We didn't have a big enough study to really show a definitive effect, but we wanted to look if things were even moving in the right direction. In terms of fidelity, we had people, because we remember we were training people, I mentioned they were training graduate students to do this intervention, so they weren't paraprofessionals, they weren't people off the street. So in Mexico, someone who has a psychological degree might have only a year or two of college even. But we trained master's level interventionists to do this. So we wanted to look at fidelity. Could they actually follow the intervention manual, and were they using it appropriately? And so we had about 20% of them, we went back and listened to the audio sessions to make sure, and we had to check off to make sure they were covering what they were supposed to in terms of CBT AD. So what about, this is mainly a feasibility and acceptability study. Can you do this? If you build it, will they come? Will they like it? You know, some of them hadn't been in individual therapy before. Attrition was less than 20%. We were happy about that. I acknowledge we paid people to come to some of the sessions. That might have been an incentive. Very few eligible patients declined. We're happy to see that. We were wondering if this would be something that has just completely, you know, culturally not what they wanted to do. Airing your dirty laundry in front of a therapist might not be something they were interested in. I've done some work in China as well, where this is an issue maybe we'll have time in the discussion to talk about. But we were happy to see that people were willing to come. The exit interviews tend to be very highly positive. They like the psychoeducation A lot of times with a highly stigmatized population, framing things as education, not therapy for mental illness is more effective. And they like the activity schedule. It made sense for them. They could work it into the daily life. It was adaptable. Several reported that cognitive restructuring was difficult and intrusive. It's hard to understand and hard to bring into their everyday life. The therapist noted that literacy was often an issue in the language ability. A lot of materials written just too high level. Cognitive restructuring, again, was difficult. And homework. What population isn't homework an issue for? But this, we like to say, particularly for lower educated groups, homework's a problem. I think it is actually for all folks, but we adapted this by having them do some of the homework sessions, homework in session. The outcomes were depression, adherence, and then these biomarkers as well. And I give you a few mostly visuals, not too much stats, but mostly visuals. So here people, this is baseline, going straight down, this is 6 months, and then going straight down, this is 9 months. So people in the treatment condition, their self-report symptoms on the Beck started at 13, dropped down to 8, and then went down a little further. Good, that's what we like to see. The control condition dropped as well, but not as precipitously, and started to climb during the follow-up session. You notice they weren't the same at baseline. When you have small samples, you don't have the ability that everything just washes out at baseline. So we understand these people had more to improve. But still, we like to see overall that it was moving in the right direction. We didn't make people worse by being in the study. And then the clinical interview, this is the MADRS. So not just this, the first one was their self-report, what they said. The MADRS showed similar patterns, a precipitous drop or a slight increase over the follow-up. Often happens that we think we need more booster sessions, and once you take away the therapy, often it's needed again. The control also dropped, even during the booster session. But not as precipitously as the other. This is the self-report of the adherence. How good do you think your adherence is over the past couple weeks? And in a treatment condition, a clear improvement over time, whereas the control condition dropped and didn't improve until the booster session. So again, it wasn't similar at the line. These are significant, showing a better effect overall. The line for the treatment was bigger. Pillbox monitoring was different, totally different. And look at this difference. When you ask people something or you have a more subjective measure of it, everyone said adherence is going up, Pillbox says not so much. But remember that Pillbox adherence, you have to use the thing. So you don't know if it says non-adherence because you didn't use the Pillbox, you didn't fill it up, you didn't have it with you when you took your meds, you were on a date and it was hidden, your parents were home, so you turned the thing off because you couldn't stand the beeping, remember, it had a reminder. So it's different. I think the people say that reports of adherence are overinflated. I think when you use subjective measures, they're underestimates as well. So the truth is somewhere in between these two slides. But you often see this in adherence research. Over time, there's adherence fatigue. People get sick of taking their medications. They get sick of using a box, perhaps, with this. But we were happy to see the treatment at least didn't slide as much, actually improved a little bit, but did, once again, over that booster phase, over that follow-up, when they were only getting a couple sessions instead of 10 or 15, they just couldn't keep up that level of adherence. And the control group just not doing very well. That was actually a significant difference, too. Didn't have as much luck with the biological measures. Could you actually impact viral loads? It's always the holy grail when you're doing NIH research. Okay, we care what they say, we care about this fancy technology, but show us the blood tests, show us the money, show us the labs. Is there really a difference? The drugs are so effective now, everyone gets better. So over time, they're getting better. The immune system is responding almost identically in both groups, although again, the treatment group is better off at baseline, but no difference between conditions here. And in terms of viral load, very high level, kind of a ceiling effect. About 80% of people were completely undetectable in terms of HIV in their blood. So they dropped slightly over time, maybe a little bit more in the treatment group, but nothing that was significant that we could show. So limitations, we had a small sample. It was a pilot study. We're waiting for more money to do a larger study. We had an abbreviated follow-up period. We didn't have a full time and attention control. And we combined two things really, right? We did the CBT-AD and we did the pill boxes. So we really don't know. Maybe the pill boxes alone would have shown that effect. Maybe the CBT, maybe we didn't need the pill boxes. We don't know. We need a dismantling study to look at that a little bit more closely. So our conclusions, you can adapt an intervention that's developed and tested in non-Hispanic white context for Latinos on the border. It's feasible. They seem to be highly interested. There's low attrition. The challenges are the literacy and language issue with some of the CBT content and the homework. And you have to take into account a lot of factors that weren't even mentioned in the manual. Stigma of HIV and homosexuality, the importance of family and religion, multiple other stressors, the low income. And also you can train graduate students to do something like this. I'm going to end by acknowledging the folks we worked with, the clinic, the community clinic that we worked, and the providers there, the consultants, Steve Saffron, my friend and colleague, and his associates, Andres, who did a lot of supervision, and the people at both at UW and here. Acknowledge John Weeby, who was the site PI, my main collaborator, who did most of the overseeing of the project in El Paso. John Soseda, who was our main minority supplement recipient, and who's now at the UCSF at CAPS. Giselle Sanchez, who's in Miami and practice now, did the bulk of the interviews. And an army of undergraduates that worked with us here. Here we are at John's house or in their local diner, having dinner at the end of the project. That's it. Thank you very much. I'm happy to take questions and can even tell you some of the future directions, what we're thinking about doing. I was supposed to go back and do something. You were going to tell me how to get to the other, in case other people have notes. Yep.
Is there a way to compare what's going on with adherence in people who are not participating at all to get a handle on what are active elements in your control group? Or is that just too hard to do? Validly or ethically.
So could I look at subgroups of people in my control group specifically, or both?
I was wondering if there's a waitlist control or something that you get a sense of what happens with the pillbox. Because the pillbox is a potentially powerful message.
Yeah, there have been studies. Some people have shown that the pillbox does, at least initially, because of the novelty, people start using it more. And we did a study here. I reported on one of the lunch and learns at Harborview where we used a men's cap, which is just one bottle that you open and it records a device. And people came up to us at the end of the study. Thank you so much. The study was great. I love this bottle. It reminded me to take my medications. It definitely helped me. They were in the control condition. So that was supposed to be just a neutral assessment of what they were doing. What they say, whether what they said really affected the adherence, I don't know. More careful studies have shown that maybe there's a novelty effect, and if you use a device, it helps in the beginning, but it generally is not enough just having a reminder, especially with a population member who has depression also. That's what Steve found. Even if you do something that helps the adherence, in Steve's Life Steps program, he used more than the bottle. I mean, he used a whole series of behavioral interventions to help them, as well as having an electronic reminder. It generally is not enough. And I like to say, if it was enough, we wouldn't be doing all these other things. Thank God we awesome. We just give someone a little reminder, would ring, and they would take their medications all the time. But it just with people, especially with people who are depressed, it just tended not to be enough. But good question. Yeah?
Was substance abuse taken into account in this treatment?
Yeah, another very good question. The substance abuse taken into account. Well, there actually wasn't. Alcohol was the main drug. In our population, a lot of them, we didn't have the money to afford much of the drugs. It wasn't, and despite the drug trafficking right below the city, there was not a huge epidemic of men. I mean, more stimulant use among gay men, but still it was mainly alcohol. We unfortunately had to exclude the people who were active users because they just couldn't commit to the therapies we had to go to. But just like you find that you have to treat non-adherence in the context of depression, I think you have to treat the depression non-adherence in the context of substance use when you're working with substance users. And they have tried with other interventions, as you can imagine. It's just that much more difficult, especially for people who aren't quite ready to address the substance use. Yes?
The presentation. Literacy, I guess, defining literacy. So folks that just low levels of education, vocabulary, can actually not read or write.
Okay, so defining literacy. Most people could read and write. They had some levels of education, but some very scant. Had come from Mexico, had been in school for a couple of years. I don't think there's anyone besides that boxer who was completely illiterate, so they could fill out the forms, but pretty low literacy. Steph Kaushman's done interesting work on literacy versus health literacy. They're not exactly the same. So you might even be able to read and write, maybe more than a second grade level, but when it comes to understanding your pills and how you take them and what's resistant and how you read the label, and if it says 3 times a day, how the heck, when do you actually take them? So it's interesting. In the back.
So, the slide that you showed about medication adherence shows that you guys are observing people take medication for less than 60% of the time. I'm wondering what the conversations were with the HIV prescriber feel like it's Madison, for example, people get freaked out if you're observing, and they don't take the next 60% of the time. What are those conversations like?
Yeah, so what were conversations, let's just repeat the questions. What were the conversations like with people who, around the low adherence in the clinic? So a couple caveats. First of all, I don't know they totally trust the expensive objective measure pill bottle that we used, the reminder. Like I said, a lot of people, non-use was a big issue in it. So I think that those were probably underestimates. Remember, people's self-reports were much higher than that. They were taking the medication much more often than that. But although this wasn't, what's interesting, this study did not use as a part of our intervention the feedback from those. We didn't want a third thing intervening with the potential treatment effects. But there have been studies that actually use the feedback from these electronic devices. Hey, look, I have here in front of me, you can see this in diabetes clinics, right? I have here, this is your adherence over the week. And it says over the last month, maybe, since you came in. And I'm noticing you're missing every weekend dose. What's going on? Oh, that's when I'm out of town and I forget my drugs, or I stay with my family and I can't let them know I'm taking it. Or so that has been used as a kind of intervention. Unfortunately, a lot of that work's been done by not psychologists, nothing against MDs who don't also have a psychological behavioral training, but they often don't specify what they do in those interviews. And that's what's so important, not just looking at, do you look at the reports and say, oh, you were bad, you punished them. This is horrible, you're telling me you're taking your drugs and here I can see you're not. Do you try to use some adherence, motivation, do some kind of motivational enhancement? Do you try to work on problem-solving skills with them? Do you look at barriers with them? Do you bring in a partner that will be an adherence supporter? There's a lot of behavioral techniques that you can use that need to be specified and tested. And it's not clear just from looking at a chart that a provider's going to know how to do that. And I think it's unfair just to say, here, do this, and then you can improve their adherence. We know in general that assessment and monitoring generally improves behavior, right? If you go home and tell people, count how many cigarettes you smoked this week, they'll smoke fewer than you did the week before, just because when you're assessing something, you will. But it's usually not powerful enough to have an impact. So I'll say one more thing about those conversations with patients when the docs think that the patients aren't taking the medication. I was at a conference this year where I said something kind of provocative and about adherence and saying maybe we shouldn't even ask. Not because we don't care, not because it's not important, but because the research showed basically the patients often overestimate. When they sit in front of the doctor who they want to please, and they do want to take their medications, they can't help but saying, I did, I took them every day, or almost every day, or most days. But it's really helpful to know that, and to put them in a painful position of not. That I suggested maybe saying something different, like, I know you've been on these meds for 5 years now, and a lot of my patients are talking about how it gets harder sometimes over time. How have you been finding it? Opening up a conversation, not shutting it down by basically forcing them to lie to you, to tell you they're taking your drug. And most doctors, you're taking your meds, right? You're taking every drug, right, every dose, right? Okay, and then moving on. But actually trying to open up a conversation and not to shut one down. Yeah. Other questions? Yeah.
What are the next steps with it?
Yeah. So thank you for asking that. I didn't plan that. So a couple of different things. We're trying to. In some places, they don't even have the peers to do this. They don't even have the paraprofessionals. So we're trying to work in China now with a computer-based version of this. And you guys know they're trying to use computers to do therapy for a while, and the really sophisticated ones have avatars that try to show emotion and depict emotion. But ours is not so fancy. We're trying to work with a nurse because there seems to be a minimum amount of human involvement that seems to be essential to working with these, especially with depressed patients. So we're trying to come up with a program for people recently diagnosed and upset about the diagnosis because of the stigma. I'm not calling it depression with a capital D, I'm calling it disclosure distress. And we're using CBT-based, kind of like the CBT-AD, but not as full-fledged depression treatment, to deal with the stigma of it. So we have, so for people who get their diagnosis in China, it's really still horrible, the acute stigma. They get their diagnosis, they go move to another city, go live in an apartment with their husband, don't tell anybody in the city. They're not working, they're just completely shut off from their lives. They're so mortified by having the infection. So we're trying to reach people like that could look online, they could see examples of other people, how they dealt with it, and we could give them psychoeducation. We could teach them about behavioral activation, and then maybe even give them homework and charts and activities, teach them problem-solving skills. The cognitive restructuring is still harder. It's a hard thing for us to figure out how to do that well online. But that's one direction we're going with that, how you would do it in terms of computer-based program. And in China, we did it just with the nurse without the computer, and so found that that was effective. We could actually do that. We didn't target depression specifically, but that's one way we tried to do that. Yeah.
Do you think that would be problematic in the kind of community, compared to community in El Paso, if there was any computer?
Yeah, so in El Paso, would they like the computers? Probably not, and that's why I went to China, because of high adoption of technology. But we actually asked, that was our next step in China, can we do, I'm sorry, in El Paso, but people didn't even have smartphones. We just thought it would not be appropriate. We did actually, and the other study I'm trying to get funded is in Mexico City, trying to look at whether there's more of a substance use issue as well, seeing if we can do a dismantling study to find out what really works with CBT. Can we just scrap the cognitive restructuring? Some early studies have shown it's not the most important piece, that maybe behavioral modification is. We're trying to go in the clinics and see if we can do it with lower level providers, maybe at most master's level, to try to do that. But a good question. We're not thinking it would be most relevant for this population. Last question. It's off to 1 o'clock. Okay, thank you.
Thank you.
Yeah.